Thank you, everyone, for joining us. Looks like everyone's been able to get connected. We are going to get started, and with that, I will pass it over to Dr. Kyle Weil with the National Cancer Institute. Carol, go ahead.
Hello, everyone, and welcome to the Enrich Forum at the National Cancer Institute. My name is Carol Weil, and I'm from the NCI's Cancer Diagnosis Program. We started the Enrich Forum in 2013 to promote dialogue and education on ethical and regulatory issues affecting cancer research. On behalf of the Enrich Forum team, I would like to thank you for joining today's WebEx presentation by Yvonne Lau from the Office for Human Research Protections at the U.S. Department of Health and Human Services. Please advance to the next slide. The lines of all listeners have been muted upon entry and will remain muted for the duration of Yvonne's presentation. If you experience any technical difficulties, please use the chat feature on the right-hand side of the screen and contact the host of the webinar to assist you. And let me depart here from my script for a minute just to thank everybody for the last-minute maneuverings in terms of recognizing that our presentation is going to be webinar only due to the weather. And we appreciate those of you who were able to join us and perhaps make last-minute plans to do so. We encourage you to submit questions by using the Q&A feature. Please type in your question and select all panelists before hitting submit. Feel free to submit your question at any time, and we will try to ask them for you on your behalf during the Q&A portion of the presentation. If we're unable to get to all questions due to time constraints, which is likely, we'll be happy to forward remaining questions to OHRP. OHRP has a mailbox you can access from its website for submitting questions. And with that, I'd like to introduce our speaker. Please advance to the next slide. Dr. Yvonne Lau is the Director of the Division of Education and Development at the HHS Office for Human Research Protection. She joined OHRP in June of 2014 from the Office of Extramural Research at the NIH, where she served as the Extramural Research Integrity Officer. Dr. Lau has also worked with the NIH Office of Extramural Program as Human Subject Specialist and has served on the Institutional Review Board of the MedStar Health Research Institute in Maryland. In addition to her medical degree from the University of Hong Kong, Dr. Lau has obtained a Master in Bioethics and Health Law, as well as a PhD in Bioethics from the University of Otago in New Zealand. And now I will turn things over to Yvonne for her presentation.
Hello, everybody. Can you hear me well? So my name is Yvonne Lau, and thank you, Carol, for the invitation to speak to this audience of from the NCI. I was really looking forward to be able to come and visit NCI at Shady Grove. I've been looking forward to coming to see the building, but it seems like every time this opportunity escapes me somehow. So I'm gonna get there one day. Anyway, so today I'm going to be talking about informed consent in the era of the revised common rule. So I'll start with this short disclaimer. Since we are very new into the rule, there are many things that our policy staff are still hoping to develop guidance on. So I just want to include this disclaimer in case if I've said anything that may not be compatible with what HHS is thinking about, then it's all my fault. That said, I would try to be as accurate as possible on how we're thinking about the revised common rule. For today's presentation, I've divided the talk into three parts. I will just say a few things about the transition period for the revised rule. I will spend most of my time talking about the key changes to the informed consent requirements. And hopefully I will have some time left to talk about this other part of the equation, which is the informed consent requirements for secondary research with identifiable private information and identifiable biospecimens. So as many of you already know, it has taken many years for the revision process to finally come to this set of new provisions in the revised rule. It's taken many years, and the goal of doing that was actually because of the changing landscape in research, that there was need to change some of the provisions in the rule so that they can better protect research subjects moving forward, and to reduce some of the administrative burdens, not just to let the IRB and the IRB staff off the hook so much as to provide them with more time to review and to spend more time to review the research that really deserves their attention. So the revisions to the Common Rule actually were first published on January 19, 2017, almost 2 years ago. And it was always the plan that it would not come into effect right away. Now, the revisions are to the Common Rule only, and as many of you know, that refers to 45 Code of Federal Regulation, Part 46, Subpart A only. So the other subparts were not changed in the process. That said, because of some of the provisions, especially the provisions with regards to exemptions, they could have some impact on how they are applied to the subparts. And so OHRP's policy staff are working on some administrative changes, the corresponding administrative changes to the subparts as well. Now, throughout the presentation, and indeed going forward, you would, when you come to visit OHRP website or hear us talk about the rule, you will hear us refer to the revisions or to the revised common rule as the revised common rule, obviously, or sometimes we would just simply say the new rule. But the official name, the official term for it is actually the 2018 requirements. We just don't like using that very much because without knowing the history of it, it's, some people would find it very hard to understand what you mean by 2018 requirements. And here is the reason. So we call it 2018 requirements because the actual effective date of the rule came about in July 19, 2018. So contrary to what a lot of people were thinking, many people towards the end of 2018, even the beginning of 2019, many people were saying, oh, we're not sure whether the rule will come about, there might be another delay. And in fact, the rule did actually become effective back in mid-July last year. The interesting thing, though, was that even though it became effective in mid-July, institutions were only allowed to make use of 3 burden-reducing provisions if they choose to make the transition. So during the period, 6 months period between mid-July 2018 and January this year, institutions, if they chose to, they could make use of 3 burden-reducing provisions of the revised rule, but nothing more. The general compliance date is January 21st, 2019, which is just over a week ago. Now, what does that mean? Before I go there, I'm going to remind you that for the purpose of the common rule, the compliance for the single IRB mandate remains to be January 20, 2020. Now, I know that this probably wouldn't affect you folks very much because there is the NIH policy for the use of single IRB that kicks into effect a lot earlier than that of the rule. Now, for all intents and purposes, when we say the general compliance date is January 21st, 2019, what exactly do we mean by that? We mean that studies initiated on or after January 21st, 2019, all these studies must start complying with the entirety of the revised common rule, except for the single IRB mandate. Now, when I say initiated, I refer to studies that are initially approved by the IRB, studies that are initially determined or that are determined to be exempt on or after that date, or studies that are able to make use of the secretarial waiver on or after that date. That's what I mean by initiated. Now, The revised rule also would apply to the following situations, and these would be studies that make use of the three burden reducing provisions described above. Now, not many, as far as I know, not many institutions actually make use of that, but we may not be completely fully aware of what's going on in the institutions. But for those institutions that did make use of the three burden reducing provisions during the so-called 6 months delay period that I talked about earlier, um, now that we have moved beyond the general compliance day, all their studies would now have to follow the full set of the revised common rule going forward. Now, the other types of studies would be studies that were initially, so the studies that have already been going on and were approved prior to January 21st, 2019. In other words, the majority of the studies that we're talking about today. So what we call the pre-2018 rule. So they were approved under the pre-2018, the old common rule. Now, what happens to those? Normally, nothing happens to them. They continue to follow the old rule, right? Unless the institutions opt to switch them over to the revised rule on or after January 21st, 2019. Now, institutions can make this decision for transitioning a group of, or all the studies, or none of the studies from their institutions that were approved under the old rule. But once they've made that decision to transition to the new rule, the studies cannot go back to the old rule. So once that transition is made, there's no going back. And once the transition is made, then those studies going forward, all the new IRB actions, will need to comply with the revised rule. Now, we're not here today to talk about the transition. There are many kind of bits and pieces of information, details on how people actually process this. You can find information on our website. There is a guidance that talk about the transition process on our website. So with that out of the way, I'm going to move to talk about the key changes to the informed consent requirements. And some of the changes are made to facilitate research, so removing some of the burdens. And some of the changes were made to improve, to better protect subjects, so to improve respect for people, improve protections. Now, as we all know, except for under some situations, majority of the human subjects research, before an investigator can conduct such human subjects research, they're required to obtain the legally effective informed consent of the subject or subject's legally authorized representative. And there is a definition here for legally authorized representative. It refers to an individual or other body authorized under applicable law to consent on behalf of the prospective subject to the subject's participation in the procedures involved in the research. In short, an LAR is somebody who is authorized under applicable law to consent on behalf of the subject for research procedures that the subject will undergo. So that is a kind of very limited definition. Under the pre-2018 rule, in order to make it, because many kind of jurisdictions don't actually have laws stipulating who would be authorized to make such decisions for research procedures. So under the old rule, OHRP accepted that those who are authorized by law to consent for corresponding clinical procedures, so procedures under the clinical setting. So those will be okay, those will be acceptable as LAR for the subjects as well. Now, that said, we understand that there's still many states and jurisdictions that actually don't even have such laws stipulating who would be authorized to consent on behalf of subjects for clinical procedures. So moving forward, there's a new flexibility under the revised common rule. So we have introduced this idea that if there's no applicable law on LAR, this can be an individual recognized by institutional policy as acceptable for providing consent in the non-research context on behalf of the subject to the subject's participation in the procedures involved in the research. In other words, we now accept individuals who are recognized by institutional policies to consent for the procedures in the non-research context. Now, we understand that, and this is like a decision that was made after receiving comments from many institutions when the NPRM, the Notice of Proposed Rulemaking, was published. We received many comments that a policy like this would be very, very helpful to institutions, and that's why this has been adopted. So it provides some flexibility. I think it'd be useful in the clinical context for many of you. Now, these are the key features of informed consent. We want to provide information through the informed consent process, to provide information that are needed for an informed decision. We want to provide that information in a way that is understandable to the potential subject, and also under circumstances that they can make a voluntary decision to their participation. So these are the well-established expectations for informed consent. The revisions to the Common Rule include new requirements to make consent more meaningful to potential research participants. And what I mean by that is that we are really kind of hoping to see consent as more like a decision aid to really genuinely be able to help people make a decision about their participation. And this is particularly important in the clinical context because, as we all know, information, healthcare information, medical information, they're notorious to be complex and requires some sort of professional training to really understand implications and so on. So many of our subjects probably don't have that kind of knowledge, and I'm not even I'm referring to people who are whether they they received extensive tertiary education or not. Often, if they were not trained in the medical field, they also have difficulty in understanding the implications of some of the information in a clinical study. The other thing also is that, we have to remember that, in the clinical context, often the decision actually has impact on the person's health. And of course, most of us are really kind of, pay attention to our own health and want to maintain, good health and have all the good benefits. So one of the first general improvement is that in the revised Common Rule, there's now explicitly a standard of the type of information that needs to be provided to subject. It says the prospective subject must be provided with the information that a reasonable person would want to have in order to make an informed decision about whether to participate. All right, so there's this standard, reasonable person standard that is introduced. It is a standard actually, to be honest, I would expect to be fairly familiar to many clinicians, right? What the subjects would want to know requires really putting one in the shoes of the subject. And of course, in the clinical situation, often we're talking about the individual patients in front of us. But in the research setting, we probably would be referring to the subject population of which we're interested in recruiting them into the research. Now, so the focus is now placed on the subjects or the subject population. And this requires us to think about what kind of information they would really want to know, and that would help them to make this decision about participation. Here, I'm going to give you an example. Right, many years ago, women who had early stage cancer would have mastectomy and axillary lymph node dissection. So there were women with early stage 2 breast cancer, where they have, the mastectomy, and then they have, one lymph nodes or none, so 1 to 3 lymph nodes or fewer. And at the time, there was a question as to whether giving additional radiotherapy to the chest wall would be helpful to these women. Because at the time, physicians knew that for those women who had more lymph nodes, um, 4 or more, they seem to be a group that benefited from getting additional radiotherapy to the chest wall. But and of course, then receiving radiotherapy, you could have, problems with the skin, and you could also have problems with getting lymphoedema, and so on. And at the time, when radiotherapy was not so fine-tuned, there might also have been worries about higher risks of getting cardiovascular or lung disease from that. So there was a question that physicians wanted to be answered, and they were interested to find out really, for those people, for those women who have fairly early stage with, fewer than 3 lymph nodes and have a good, mastectomy, a clearance, would they also benefit at all? And if so, are we talking about just a local control type of benefit, or were we talking about, survival benefits? And so they were hoping to maybe do a randomized control trial to find out. Right. So I guess if, we're thinking about a randomized control trial, we would tell women, right, in the informed consent, well, so one group will get, the radiotherapy, and the other group will not. And for the group that gets radiotherapy, you could expect some skin changes, and there may be a slightly higher chance of lymphoedema developing in the future. But then there might be the possibility of some benefits, a better control locally, or long-term control. So those are kind of information that, we would hear, or we would, expect to see in an informed consent. But something that is, that of real interest is that there is something else that is of real interest here, because it turns out that, getting radiotherapy or not could be a big deal for these women, because one could imagine that because they have, stage 2 cancer and they have had the mastectomy, many women in the process of recovery, they might be interested in considering some sort of breast reconstruction. And of course, the standard reconstructive procedures would be either through an implant or, do some muscle flaps. And many women would probably choose having an implant because it's kind of an easier procedure and so on. Now, it turns out that if a woman actually end up getting radiotherapy, right, this could seriously limit the options that they have on what kind of reconstruction that they could go for. Often they would end up having to resort to having a muscle flap type of operation, which is a much bigger operation, and there are more morbidities potentially after the operation. So one would imagine that this kind of information would be something that, a reasonable person, a reasonable woman in that situation would really want to have prior to making the decision about participation. And in my mind, if one really think about it, one could even imagine that, really, I mean, that could potentially clinch my decision as to whether I'm going to go and accept going through the study, because come to think about it, I mean, if I weren't in the study, I might have more options. Like I might have, I might decide that maybe, I'll have the implant and I'll, think about radiation later. Or, if some people are willing, some surgeons are willing to do the implant and maybe adjust the radiation dose, all that. Whereas when you go into a study, there may not be all that options for you. So, this would be very important information, one would imagine, for that could potentially determine whether somebody would agree to participate in the study or not. So another general improvement for informed consent is that in the revised rule, there's a new requirement that information presented needed to be in sufficient detail and organized and presented in a way that facilitates subjects' understanding of why one might or might not want to participate. So sufficient detail and organized and presented in a way. So often when we do see informed consent today, we often see, list and list of, many pages of, facts after facts after facts. And often they are kind of just presented in an isolated manner. Okay, they may be categorized under risk or potential benefits, but still they kind of presented in an isolated way. And let me just give you an example. So when I was a reviewer on the IRB, I did remember that not um, um, not infrequently, I guess, I would see informed consent where the risks are laid out. One time I remember I saw risk being laid out according to the physiological systems of the body, so cardiovascular, respiratory, renal system, and then under each there are like list and list of side effects, potential side effects. And I was sitting there and wondering, okay, I was a physician by training, and even I have difficulty in really understanding, well, okay, so how should I really process this information for it to be useful for me? So it is true that there's a lot of information there, and I would expect that the information to a certain extent are, yeah, factual information. But it's just that there's no way one could even, start to process that kind of information. So by giving people a lot of information doesn't necessarily mean that that information can be understandable. That, and if it's not understandable, the fact that you've given it doesn't really mean very much. So there were improvements, right? And some people would start, putting the risks together into context. And so that's an improvement. For example, by telling people what may be the most common risks, right? Or maybe telling people also what may be the most serious risks, right? That's definitely an improvement, right? And then, to improve further, some people would put percentages, not just the likelihood, but, actually also in terms of percentage. So a little bit more information with regards to when you say likely, what do you mean by that, right? Because everybody interprets that information differently. So again, that's an improvement. But then what is still missing is this thing that I find really interesting, because often when you ask people to make a decision about a course of action, so when you're presenting them with several courses of action, and you want them to make a decision about which course of action to take as opposed to another, right? Really the information that people need in order to be able to make that kind of a decision is the information about what the differences are between the two courses of action, right? And often what we have been seeing in informed consent is that the information is often fairly one-sided, right? We get a lot of factual information telling us about, the research intervention and, what would happen to us if we, happen to get the intervention. What we generally and often don't see is a discussion of, okay, so what does that mean if I get this and not that, right? And here I'm going to, give you an example again. So I have often seen, for example, in, oncology trials where you might be randomizing people to one group getting the usual chemotherapy regimen, right, consisting of drug A, B, C. And then you have another arm where you are adding a new intervention. So you have, the usual regimen, drugs A, B, C, plus a new intervention called intervention D. All right. So, and then when I go and look at the informed consent, I see risks for drug A, risks for drug B, risks for drug C, risks for drug D, and then risks for the intervention X. And I often find myself actually asking myself this question, okay, so how am I supposed to understand this? At the end of the day, what would really have been helpful for me would have been if somebody could tell me, okay, so, one regimen you're giving A, B, C, D, and the other regimen you're giving A, B, C, D, and X. So how does the two differ? Right? Can you just tell me that? If you just tell me that, I think it would have been much easier for me to kind of, conceptualize that, right? So I think, this is, I guess, really what one is trying to say here, that, time to stop just, giving people lots of information in an isolated manner, but really try to put those information into an organized manner and present it in a way that, a person, in the general public would be able to understand. I'm showing you this, a couple of years ago, many of us apply credit cards, and I, applied a credit card, and this was what I received, the terms of agreement. And I actually picked it up and looked at it because I thought, oh, this looks different from what I used to get, when it was pages of, tiny little font, black and white, and packed with, text. And again, lots of fact with, first, you don't even want to read it. And secondly, you don't think that you're going to really understand what they're trying to tell you. But this one, not only was it presented in a different way, it actually, drew my attention. I picked it up and looked at it, and I thought, oh, that's really interesting. They are really actually, trying to lay out the information in such a way that it makes some sense and it's easier to read for the general consumer. So see how it says what it means to you. Now that's really helpful because it's really drawing your attention, okay, if you see a term like that, how you need to understand this term in this context. And I thought that that was really useful. So I was wondering, well, what's happening, right? So I went to the Consumer Financial Protection Bureau website, and I found that, in fact, they had this initiative of trying to get all the credit card companies to be able to provide information that could really help consumers understand the information on their credit card agreements. Because if you remember, many years ago, there was this huge problem about people, not understanding the terms and how much interest they'll be charged, and just using their credit card in a way that was irresponsible, not because they wanted to be irresponsible, but because they really didn't understand how it all worked. So, on the Consumer Financial Protection Bureau website, there's actually a prototype of credit card agreement. And it's not, I extracted from it. It's actually laid out in a much more attractive format. It gives you some headings and it gives you some items in it. And it was up to the credit card companies, to, develop their own, however they like, but using this kind of an approach. I'm going to hold that, I'm going to ask you to hold that idea of this prototype in mind, and we'll come back to it a little bit later. So the third improvement in terms of requirements for informed consent is what we call this new requirement that certain key information must be provided first. And key information would be information about why one might or might not want to participate, and this would often include, but not limited to, information about the purposes, risks, benefits, and alternatives, all the elements, the traditional elements of informed consent and that we all are familiar with. And again, it says it must be presented in a concise and focused manner. So really repeating what we were just saying, but that there's now this thing called key information that needs to be put up front first. Now the goal of this is so that this information, this really key set of information, would be the highlight of however many pages of informed consent that you are thinking that you need. Right? So it's kind of like upfront, this is the key set of information that by going through this, people would really get a good general idea of, what this research is about. So separating, this information out from, if you like, the noises, right? One thing I want to point out here is about this thing here about why one might or might not want to participate, right? So if we look at today's informed consent, often we have no problem in finding information about, all kind of pointing to why one might probably want to participate in study. But there's never really, information that is presented in a clear manner as to tackling this question or this issue of why one might not want to participate, right? Hold that thought. Now, to explain key information better, I've decided to actually use an example that was being presented at the 2018 OHRP Exploratory Workshop on Informed Consent. So this was an initiative that we undertook last year in September. We call it an exploratory workshop, and it was on informed consent. So an example was being used in the discussion at the time, and it's shown here in this nice schematic diagram, and very easy to understand. So essentially, you're talking about men with advanced prostatic cancer that had metastasized, and physicians wanted to randomize them to one group where they received the standard of care at the time, which was just hormonal treatment, hormonal ablation treatment, and the other group, they wanted to add a new intervention, and that was the use of the docetaxel for 6 cycles. And then they're going to follow them up, and then there's some PSA testing and so on. So this is a general notion of that study. So Professor Stephen Woloshin from Dartmouth Institute for Health Policy and Clinical Practice has done a lot of work looking into how information ought to be presented in order that people could really understand. So he proposed the following as an example of what a key information on that particular study might look like. So he pointed out, well, we should talk a little bit about what the science is behind this study. So what is the new idea here? The new idea here is that, by adding a chemotherapy called docetaxel right at the beginning when we start hormonal treatment, it might lead to better, outcome. So why it might help, just a sentence or so to say, what the study is underlying, why they think this might work, right? And why it might not help, right? Some people were saying, in fact, the oncologists were wondering why, even some oncologists wondering if this would work at all, because, by giving the chemotherapy and the hormonal therapy together, you might be confounding the two treatment, and one might not, the chemotherapy might not work as well as it ought to. So the purpose of this study, and then you get to the purpose, where it's, to find out, whether by adding docetaxel right at the beginning of the study would lead to better, people living longer, and so on. So see how, we already required, this element, the purpose of the study to be included in informed consent. What in the past has been lacking is just one sentence. And again, it's kind of, not necessary one sentence like that. People don't really understand, okay, why are we doing this study? But if you actually provide a little bit of science behind it, it really helps people to conceptualize it better, right? And then he also said, well, for the key information, you really also need to tell people what the trade-offs are. So, in a way, we also refer them to like a discussion of the pros and cons. So if if it's a randomization, like with this study, you have arm A and arm B. So what does it mean? What are the differences between the two? All right. And in terms of the side effects, in terms of the benefits, and specifically, why would you not want to be in this study? And conversely, why would you want to be in this study, right? So, in a way, you can put it into a narrative whereby, you would be able to answer that question for the potential participant. So in my mind, I would imagine something like this might go on. So, so if if we're somebody who were kind of really, you know, want to be left alone, and you're worried about the side effects of the chemotherapy, you accept that probably there's not much time for you left, and you just want to be left alone, and you really don't want to go through this. Okay, that may be the reason why you wouldn't want to be in the study, because there is a 50% chance of you getting the chemotherapy. On the other hand, if you are somebody who might really be, so eager, I want to try everything under the sun, and if I could get it, one way or another, I would really want to do this. Or it could simply be, what, I'm at this, kind of stage, and, if I could do something, and it's, if I can be contribute to the advancements of science so that people after me, I might not personally benefit, but if I can contribute to the advancements, so other people that come after me would be able to benefit, all the better. So putting really, the not just describing, risks in under a risk category, or benefits under a benefit category, but really putting in, all the pros and cons into a narrative that makes sense to people. And how will the research be done, right? What are some of the procedures? And often, if we're talking about a case of randomizing people, today, we see a lot in informed consent where it says, well, this study involves randomization. It means it's like flipping a coin. You get a 50% chance of having this or 50% chance of having, the other treatment. But research has shown that, in fact, that kind of information doesn't seem to really get across to many people. And so you have still a lot of people not, going into randomized trial, not really understand what the implications are. But if you were able to say it more clearly, for example, that what it really means is that you need to be okay, right, with both arms, the one that gets the chemotherapy or the one that doesn't get the chemotherapy. You need to be okay with the possibility of getting either of these group of treatment, right? And that's what it means. And the other thing is that uh, 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 you need to acknowledge and accept the fact that, well, this is not a decision made tailor-made to your situation by your doctor, between your doctor and yourself. This is a decision that is made through this process required by the research, and that is not subject to your doctor's input here. So those are the kind of things that maybe it is worthwhile to make it clearer to people. So coming back to this, with all that we've talked about, these new requirements, maybe we could, come to some sort of an idea as to what might a prototype of key information document for a clinical study would look like. And here is just a possibility, right? We could start by, identifying who is this research for, right? What's the problem with the current treatment? Right? Why are investigators doing this research? Right? Obviously, there usually is there is a problem with what we have now, and that people want to improve on it. Right? What do they hope to find out about the research intervention? Right? How will the research be done? What exactly does it mean by being randomized? And how will the treatment groups differ in risk, benefits, and other important aspects? Right? So that could sometimes translate into how might being in the study or not affect the health of the participants, and why might one want or not want to participate. Right? Think about all the examples that I presented to you. The mastectomy patients, presented with an opportunity to have radiotherapy, um, undergo radiotherapy as part of a study, um, and then the prostate cancer one, right? And I added this item here: who will pay for the treatments and procedures and the research? And we've noticed that, from interacting with our constituents, that many of them actually voice that, this is something that many patients actually are concerned about. Now, key information likely is going to differ from study to study, and so let's just consider some examples as an illustration. So, an explanation of how participating or not might impact the subject's health, right? Obviously, this most likely would be key information in a biomedical research studying treatment interventions. But on the other hand, if we were just doing a questionnaire study inquiring about dietary habits, right? There's really not much impact or not on the health of subjects, and even in terms of, potential risk and so on, there might not be many. So probably, this would not be key information for this kind of study. What about information about sponsor, right? So it could potentially be key information in a high-risk new drug trial. Think Jesse Gelsinger, right? Or a non-inferiority pharma trial comparing their own drug, and all these drugs are on the market already with similar profile, but they just want to make sure, and show people that, their drug is as good as the others, right? So people might have a reason to know, well, this is a pharma-sponsored study for this purpose. But then information about sponsor would not be so much relevant in a study looking at hospital workflows to improve health outcome. And what about the amount of compensation for participating in a study? Right? We don't like to talk about money very much, but it could really be key information for a study where healthy volunteers are involved and they're asked to participate in a phase 1 trial in which they do not stand to benefit. On the other hand, in a study like the one we talked about with advanced patient with advanced prostate cancer, it'd be quite unimportant for patients whose final hope for any treatment is through participating in the clinical study, right? That's probably the last thing that they care about. So now we're going to move away from these new key requirements and move to talk a little bit about some of the basic elements and the other changes. So in terms of basic element, there's one new basic element, and it is a notice regarding possible future use of data stripped of identifiers. This is put there for transparency purpose. So as we all know, a lot of today's data and materials, once stripped of identifiers, they go to secondary research, and many people are utilizing these materials for secondary research without people's identifiers. In the general public, it may not be something that people are aware of, and by providing a notice like this, we hope that we could raise the transparency of this kind of practice. Now, if investigators are dealing with very population that have cultural sensitivity, and they really have made a decision that they will not use the data ever for future research, then they can also say that. So it's really just a notice. I think I need to go faster. So additional elements, notice about possible commercial profit if the subject's biospecimens are likely to be used and in such a way that it would lead to commercial profit. You need to include this notice. Notice about whether clinical relevant research results will be given to subjects, and a notice about whether research might include whole genome sequencing. So these are the new basic element and the new additional elements. Notice that they have moved from A to B here and from B to C here. Screening, recruiting, or determining eligibility. There's new flexibility for IRB. So under the old rule, as part of the research, if investigators need to contact subjects to screen them, to recruit them, or to determine eligibility, they need to go through the IRB, and the IRB needs to take an additional step of waiving the requirement for informed consent to allow researchers to go and do that. But going forward, under the revised common rule, this has been eliminated if the information is obtained through oral or written communication with the subject, or it involves just accessing medical records or stored identifiable biospecimens. There is also a new requirement for posting clinical trial consent forms. For clinical trials supported by federal funding, one IRB-approved consent form used to enroll participants must be posted on a designated public federal site. And I think for your purpose, it will most likely be the clinicaltrials.gov. And so we're talking about just one approved consent that has been used to enroll participants. So if you have multiple versions of that, it doesn't matter. You don't need to keep changing or providing the most updated one. You just need to provide one. And the consent is posted after recruitment closes, no later than 60 days after the last study visit. The point of this is for transparency. And remember what we talked about prototypes. In a way, if you go to the Consumer Bureau website, you see many different, terms of agreement posted by different banks that you can see there. And the idea is that people can look at them and see, and take them as examples, or copy the good things and discard the not so good things, right? So similarly, for this, the posting requirements really so that we could actually have some examples to look at, and we can pick the good ones and learn from them. So federal department or agency may permit or require redactions. All right, so I'm already at 3:50, and in this part of I'm going to just go very quickly and use 5 minutes to go through this very quickly. Carol did ask me to include that if it's possible, and it is on secondary research. So secondary research is use of information or biospecimens originally collected for non-research purposes or for research studies other than the proposed one. In other words, this materials are being collected with or without your research. Your research really should have no impact on the collection of this material. So that would be secondary research. The options for secondary research using information or biospecimens with identifiers retained, right? These are the options that you can do such research. Okay, so you go and get people's standard informed consent for the use of this material, right? Or you go and ask the IRB to obtain a waiver of consent from the IRB. A lot of people are doing that today. Um, and there's a new third option, which is obtain broad consent as described in the revised common rule for broad future secondary use. And when there is broad consent, there is a possibility of using it with exemptions, the new exemptions 7 and 8 as well. And then there is a fourth option. So under the new rule for data only, not biospecimens, some of the studies could potentially fall under the exemption for HIPAA provision, all right? And of course, we are talking about secondary research with identifiable materials because most of us know, secondary research with informational biospecimens that cannot be linked back to individuals is either exempt or not considered human subjects research. So this is a limitation of, there's a limitation for the standard informed consent for future unspecified use. We get this question a lot. Can standard informed consent to create a tissue repository or data bank meet the informed consent requirements for a subsequent study? It depends, right? It would if the original consent meets the requirements of, all the 45 CFR 46116 requirements for the specific secondary research study that you're thinking of doing. So think about it. The more general the original informed consent document is, the less likely it is to satisfy this requirement for that subsequent specific secondary research study. That said, don't forget, of course, that a lot of the tissue repository or data bank, when they do give out materials for subsequent secondary research, they do so in an unidentifiable manner. So researchers come and said, can you give us the materials for the secondary research, but we don't need identifiers. Now that is outside of our regulations. It is only when they want to use identifiers. So since the standard regular consent that we know of has that limitation. You need to have been able to describe it specific enough for you to be able to use down the road. Now we have this new option, and I specify that this is a new option. I know that this term broad consent is being used or has been used under the old rule context. But that, just a reminder, in the old common rule, there wasn't really a mention of this broad consent, all right? However, under the revised common rule, we do have this term called broad consent, and it is an option permissible only for secondary research using identifiable private information or identifiable biospecimens. It can be used as a means of enabling subjects to agree to a broader range of secondary research studies in the future when the details of this future research may not be available. So it's kind of answering the question that we talked about earlier. If we want to do research but we're not able to really completely describe the details, then maybe this is the consent that would be useful. We envision that investigators would probably be obtaining the broad consent at the time when the standard informed consent is being obtained through the research interaction or intervention with subjects. So if you're doing a clinical trial, and you think down the road, the information that we're collecting for this clinical trial, we probably would use it, for other research, or other researchers might come and want to ask us for them for use in other research in an identifiable manner. So if you're already thinking ahead like that, you might want to consider, including this broad consent in your consent process, right? Or we anticipate that people would be using a broad consent in the non-research setting when the informational biospecimens are collected. Say in a clinic situation, you go to see a doctor, people go to see doctors, and there's a lot of information already being collected, and some major, healthcare centers might start to, use these broad consent to ask for materials, for people to give permission for the materials to use with identifiers, right? So use of broad consent may be used for non-exempt studies like the normal standard studies that go through IRB, or to qualify for the new exemption 7 or 8, which I'm not going into in this presentation. Now, notice that if used, all of the elements for broad consent must be included. And I advise you to go and look at 46116D, where it lays out all the elements required under the broad consent. Right? These include, amongst others, a general description of the types of research that may be conducted, the types of institutions or research who might conduct research with the subject's information or biospecimens. So there's quite a few items that of information that you still need to provide, even though you may not need to provide a specificity, right? So there's no flexibility. Notice that there's no flexibility for alteration of these elements. Other limitations of broad consent. If individuals were asked and refused to provide the broad consent, the IRB cannot waive informed consent to the use of the subject's identifiable private information of biospecimens in secondary research. So you lose that waiver. If people refuse to give you the broad consent, down the road you go and ask for IRB waiver of consent for those subjects' materials, you lose the opportunity for IRB to say, oh, let's waive it and you can use it. No, you wouldn't be able to. However, you'll still be able to use the subject materials in a non-identifiable manner. So use of broad consent will obviously involve some mechanism for tracking the affected information or biospecimens, and there may be cost and logistics involved. And so it may or may not be a choice for smaller research centers. The last bit of information, IRB waiver of alteration of informed consent. Many investigators are familiar with this concept. If they want to use material for secondary research, they want to use materials in an identifiable manner, and they feel that they are unable to go back and ask individual subjects for their consent, so they'll come to the IRB and say, well, can you grant us a waiver of the informed consent? So these are the conditions, the known conditions that we're all familiar with. However, in the revised common rule, there is a new additional condition that needs to be satisfied before the IRB can actually grant such a waiver. So this new condition is, if research involves using identifiable private information or identifiable biospecimens, the IRB must determine that the research could not practicably be carried out without using such materials in an identifiable format. And this practicable here follows the same kind of concept as the practicable idea in HIPAA. So the idea is to nudge people to use non-identifiable information whenever it's actually feasible, to try to stay away from using identity, so it's more protective that way. So that's the end of my presentation. I'm afraid I've used up all my time and over. So please refer to the text of the revised common rule available on our website for complete and accurate description of the requirements, because in my presentation I've tried to simplify things, and our lawyers don't always like that, but do go and read the actual text. If you want to contact us for questions, that's the email address to go for, ohrp@hhs.gov. We promise that we try to respond to you within 5 days, and often we would respond within a day or two. And sometimes if we don't actually have the answer right away, we will acknowledge receipt of your email and go back to you, right, when we have the answer. So this is our website, but this is the one that I want you to note. Bookmark this page. We have created this, what I call as the gateway page, to all the resources related to the revised common rule. So there are question and answers, there are videos there. So this is the page you want to bookmark if you're interested in the revised common rule. And last but not least, I want to remind you that for 2 years now, we have introduced this new website, hhs.gov/about-research-participation. And we dedicate this site to materials, videos, infographics, resources that are developed with the general public in mind to help raise their educational level or their understanding of research and so on. We just released a new video on social behavioral research, what it is. And so with that in mind, thank you so much for your attention. I hope that, people want to ask questions. I'm happy to. Passing on to you, Carol. I'm sorry, I've used up your time as well.
No worries. Thank you. Thank you, Yvonne, for a wonderful speech and presentation on the new consent rules. And I am going to address a couple of questions that have come in from the internet. First, if you can address what your interpretation or what OHRP's interpretation means by use of the words non-identifiable. So in other words, if data are de-identified, but if there is a collaborator who holds the key or a link to personal identifiers, is that considered de-identified or non-identifiable? Is there some distinction you're drawing between non-identifiable and de-identified?
Yeah, so this is a confusion for a lot of people. We always kind of think about the whole research project as a whole. So in theory, this is the case. So if one investigator actually holds all the identifiers to that set of data, right? And this investigator is very much involved in the research project, all right? So we would generally consider that type of research as having identifiable information there because there are links. There are direct links that they can easily access, right? Now, I know that, research is being done in many different ways. And so there are some institutions where they would create a firewall and such that, and also the investigators or the people who hold the original identifiers or key to the identifiers, they are not really involved in the research. They are really just provider of materials, right? And they provide in such a way without identifiers to the actual group of investigators for them to work on. So in other words, looking from the group of investigators who are doing the secondary research, and we say, well, they don't have a ready means to link the materials back to individual subjects in that way. That to us is not identifiable, all right? We don't really use the HIPAA, limited data set criteria and so on. But I have to say, all this business about what is identifiable, what is not, in the revised common rule, there is a commitment there to say that OHRP and other common rule agencies will revisit this concept every so often, because we understand that moving forward with the changes in technologies and so on, that how we think about identifiability could change. And in fact, I believe that the first commitment is that by within this year, sometime this year, that the common rule agencies ought to have already revisited this idea and determine if they want to change that definition.
Okay, so just for some clarification, would the word non-identifiable or not identifiable be more appropriate for a common rule concept of non-identifiability, and de-identified is more appropriate for HIPAA, and in other words, not meeting the 18 criteria in the HIPAA rule? Is that a good sort of vocabulary tool to use?
Well, for us, it's whether the investigator, the team of investigators working on that secondary research projects could readily link the materials back to individuals. All right. So to us, when you say de-identify, it's almost like a mechanism of rendering it not identifiable. But if within that group of investigators, somebody still holds the link for it to be, for them to be able to readily, kind of find out,
re-identify,
comparing
right.
to a child, re-identify, then it's not, it doesn't meet our purpose when we say it cannot be readily linked back. But so there's I know our definition is tricky.
Okay, I know we're getting short on time. I am going to ask one more question that's come in. If an institution jumps through the hoops and is able to meet the criteria for the broad consent exemptions, and therefore has a policy and a process for seeking broad consent from individuals, and if in a particular protocol there are individuals who refuse or decline that broad consent, then I believe it is still the case that the tissue collected in such a protocol could be de-identified, or I guess I should say made non-identifiable after our last discussion, and then used for any research use whatsoever, despite the fact that someone has been asked whether they will agree to a broad consent for purposes of the use of future uses of their tissue and has said, no, you cannot do that. isn't it still the case that their tissue can be used in future research without their permission if it is de-identified?
Yes, yes, yes. And I think that, I think the curious thing, of course, I mean, comes from the kind of situation as to how our rules are actually constructed, right? Because when you do secondary research and you do secondary research using materials, individuals' materials that do not have identifiers, you're really outside of the scope of the regulations, right? So it makes it, because of that, it makes it kind of strange. You might almost think, wow, is there an ethical issue here, right? Because the subjects, you did ask them to provide broad consent, they said no, right? But don't forget, the broad consent that we refer to are broad consent for use of their data and materials or their private information biospecimens in an identifiable manner, right? And what they were saying no to was for you to be able to use it in a identifiable manner, correct?
Right, but there is a new provision in the final rule that a consent form must tell people whether or not their tissue can be de-identified. Yes. And I was curious as to why that provision does not apply in the broad consent new rule. I mean, it applies for regular consent under 116, but not for broad consent, which I thought was a peculiar.
So under the regular
outcome.
Consent, yeah, you're referring to the new notice requirement in the basic element, right? And the
right.
new notice requirement is that you need to tell people, right, that if your plan is, you need to tell people that, their material, right, might be, even when stripped of identifiers, so non-identifiable, that they might be used for future research, or they will not be used for future research, right? That really serves as a kind of a notice, and it gives people the opportunity, if they really see that and they're concerned, well, they'll take that into consideration as to, when they were giving the consent for the initial research, right? That they would take that into consideration. But in a way, it's not really meant. It's really meant for transparency purpose, and it's really not meant for as an item, separate item where people could veto the research through using this or not, right? So it's really just to let people know. It's the whole goal behind that is to let people know that that this practice it's happening, right? So that sometimes, as nowadays people sometimes find out about things that they didn't realize was happening, and they get very upset about it. And I think this is one way of starting to make people know that this kind of practice is happening, and yeah.
So, but why was that transparency not thought to be appropriate for a broad consent? Because for people who refuse broad consent, they ought to be made aware that in those circumstances where they believe they're refusing to have their tissue used in the future, in fact, their tissue might still be used, but just in a de-identified manner.
I don't know. I wasn't involved in the policy development, but let me just think about this way. So broad consent is really specifically used for asking people for their identifiable materials for subsequent secondary research. This item, this notification going forward, it's present in all the informed consent where you actually collect the material, right? So this notification is there already. So it's a question of, if it's already there in the general informed consent when you're actually collecting the material, right? Does it also need to be there in the broad consent when, it's a kind of a second layer of consent?
Right, and I think what I hear you saying is that broad consent was always conceived as something that is a permission only for identifiable information and tissue. Yeah. So if we're going to de-identify it, the broad consent really isn't applicable. I think, though, that there's sort of this black hole where people are offered broad consent, but those who refuse, who may be the very, very same people who have concerns about their tissue being used for any purpose whatsoever, ought to be aware that even, that their tissue, once it's collected, can still be used, whether they give permission or not. And in fact, even if they refuse permission, their tissue can still be used. So it seems to me that that might have been something that would be useful to explain to people in a broad consent form. In any event, I know I'm sorry, go ahead, Yvonne.
Yeah, I mean, you could make that argument, but I guess when it was developed, it's kind of conceived in a way that, you have the situation where you're already interacting with subjects for research purposes, and in the as a new requirement in the informed consent going forward, you already have to include a notification about, this this materials being used or not in an unidentifiable manner, right?
Right, right.
So that information, one way or another, it's already imparted. You could argue that, well, sometimes, you do secondary research with materials that are collected in the day in and day out clinical situation when people are not thinking about research. And I think that that involves a different process there.
Yeah, well, they're very common in clinical trials.
Yes,
and
in those situations, it may be the case that, adding that in the broad consent might be
is a useful idea.
Yeah.
Yeah.
I mean, like I said, nothing prevents, nothing stops people from adding that into their broad consent.
Fair point. The OHRP rules are a floor, not a ceiling. So good point to keep in mind, particularly for a forum like ours, which is a discussion of ethical issues as well as regulatory. All right. I very much appreciate, again, Yvonne, you're taking the time and particularly working through the machinations of doing things differently due to the weather. Thank you so much. I just want to give our audience a heads up about 2 upcoming Enrich Forum webinars on February 26th and March 19th. And the details for registering for these will be available on our website. And there'll be future NIH and NCI-wide emails as well with the information. In February, we have Susan Pinney, who's the Deputy Director for the Center for Environmental Genetics and Cancer Epidemiology in Cincinnati, Ohio, and she will be speaking about returning individual level data to environmental study participants in her work. And in March, we have John Tilbert and Joel Pacina from the Mayo Clinic, who will speak about involving patient advocates in the life cycle of research. So again, Yvonne, thank you so much. Thanks, Jennifer, to you for all of the webinar logistics. And we look forward to future participation from our audience. Thanks again. Bye-bye.
Thank you, everybody.